Good evening, President sir. Sir, you are muted.
Yeah. Good evening, everybody.
Good evening.
Good evening, sir. Good evening, sir.
सुनील जी लाइव हो गए कि बताइए.
Good evening, sir.
Good evening, Deepak. Good evening.
Sir, we are live.
We are live. So, sir, with your permission, I will initiate the proceedings. It's exactly 8. So, good evening and welcome to the third episode of All India Postgraduate Teaching Program, a new initiative from ARC AIOS. This is an initiative which has been a dream for our president, Dr. Harbansh Lal sir, and he deputed the ARC team to carry on this. But at the same time, we had a challenge of having something different because there are multiple postgraduate teaching programs happening across the country. So with this particular thought in mind, we decided to have a PG program with a difference, and that was our tagline. And so we decided to cover the uncovered aspects of teaching programs like case presentation, journal clubs, OSCEs, and didactics on topics which are not comprehensively available on it in a textbook. In the very first episode, we had a case discussion on glaucoma. In the second episode, we had a journal club. So here we present our third episode of the series, which is a didactic lecture on newer glaucoma diagnostics and procedures, which has been a long question for MS exams. Today's didactic lecture would be presented by Dr. Ganesh Raman, Head Glaucoma Clinic at Arvind Hospital, Coimbatore. My special thanks also goes to Dr. Kalyani Vyas ma'am. She is a glaucoma senior consultant at HV Desai Hospital, Pune. Dr. Surajit Sen sir, he's a consultant glaucoma and cataract services at Netralayam Super Speciality Eye Care Center, Kolkata. And Dr. Shahinur Tayyab ma'am, she is a senior consultant at glaucoma department, Shankardeva Netralaya, Guwahati. And we are thankful to all of you for consenting to be a discussant for this very PG program. And of course, one of our discussant is going to be our own ARC central member, Dr. Deepak Mishra, who is a faculty at BHU and also a well-known glaucoma consultant. The first episode, we had a total viewership in 7 days of 3,820. And similarly, in the second episode, and buoyed by that, we are pursuing and trying to take it to more higher levels. Now, I would request our President AIOS, Dr. Harbansh Lal sir, to address the postgraduates before we initiate the program, because it was his dream project that we are carrying it on. Over to you, sir.
Thank you, Prashant. I think this was my dream, and actually, I visited so many places during my last 25-30 years, and some of the places teaching program is really very, very poor. In fact, in one of the UP medical colleges, one of the PG told me कि मुझे लगता है कि हमारे यहाँ के प्रोफेसर का ना अरविंद वालों से कोई साठगांठ है कि हमें कुछ सिखाते नहीं है ताकि हम अरविंद में जाके ट्रेनिंग. So that way, the standard of the postgraduate teaching is so variable. I mean, there are some institutions where the teaching is superb. To talk to them, they know everything. There are some places they even don't know how to do the basic gonioscopy, SIDLAB examination, I mean the operation tonometry, how to read the perimetry. They've got no clue about anything. And at some of the places, I think the worst part of it is many of the teachers feel that they are in competition with the students. If they teach the students, they are going to practice there and they will become their competitor, which is a very, very bad attitude from the teacher side. And at the same time, there are many students are not as respectful to their teacher as they should be. So like during my time, even the 1 year senior will come, all of us will stand and offer him the seat. So things have changed. So I request most of the postgraduates, they want best from their teacher. Of course, they have got to study, read, and work hard. And they can only offer that is the respect to their teacher, nothing else, nothing more. And it is the duty of all the teachers, whoever you are. And already written once in when I was the president DOS, that if you are not teaching your students, somewhere somebody is not teaching a word as well, whatever specialty it may be. So it is our duty to look into that. We teach them well, we train them well, and we should feel proud of their success and the students to respect the teacher. And with that in mind, I wanted that at least till the time we have got many of the places, there is not enough of work available. Many of the places, teachers are with the political connections. Many of the places, they keep on practicing. They don't have time for the teaching. So I thought that the IOS should take an initiative, and at least we should have some teaching program of ours. And when I look into it, within 3 years' time, there'll be enough of material available on the IOS website where people can go and look into it. And I'm very happy that this program has really taken off very well. And with the type of viewership we are having already, and over a period of times, it is going to run into lakhs. So I'm very happy and very proud of you, Prashant. And I'm very proud of the team, ARC, which is really working very hard. And I'm very happy that all of them are present in most of the webinars, which is very, very rare. Usually the one who is conducting is usually available. So kudos to all of you. I'm also eagerly looking forward to the didactic lectures.
Thank you, President, sir. Those kind words of advice and inspiration to the students as well as to our team. Our team, trust me, sir, is one of the best teams ever I have worked with. And I'm very proud to have such an energetic team with me. Call it Tinku, call it Deepak, call it Srinivas, call it Kasturi ma'am. Everyone is there to pour in ideas. And that's why if you look at the program which we have rolled out, it has picked up so well. So now before patting, no more patting, I believe, I think it's time for us to move ahead. It's today the session would be moderated by our own member ARC, not Dr. Tinku Bali. So over to you, Dr. Tinku, to carry forward.
Hello, good evening, everyone. On behalf of ARC, first of all, I thank you all for joining this webinar. I thank the audience, the PGs here who have joined us. It is indeed our pleasure and privilege to have Dr. Harbans Lal, who's the president of AIOS, with us this evening. I thank the expert speaker and the discussants who are with us. And I would like to start by inviting Dr. Ganesh V. Raman, who's the head of the Glaucoma Clinic at the Arvind Eye Hospital, Coimbatore. And he'll be speaking on newer glaucoma diagnostics and procedures. I'm sure this lecture is going to be full of practical pearls and nuggets and lots of take-home messages for the PGs. So over to you, Dr. Ganesh. I request you to start your lecture.
Thank you, Madam. President AOS, Harbans Lal sir, thank you very much for the opportunity. Prashant sir, thank you very much for the opportunity. I'll share my screen now.
Please.
Just 1 second.
I request the audience to keep posting their questions in the chat box so we can have a discussion at the end.
So my topic, which I'll be covering, is newer diagnostic and surgical techniques in glaucoma. And this is, as I was speaking to some of the PGs, they say this question is regularly comes up as in the 4th paper of the MS examination. So I'll be discussing a lot of products here, a lot of devices. I have no financial interest in any of the devices mentioned. And coming to the topic at hand, the newer diagnostic tools are very important because glaucoma is the 2nd leading cause of blindness in the world. By 2040, approximately 112 million people will have glaucoma, and Asia and Africa are to be likely to be affected maximally. And you need a very good, efficient detection tool, and management is also required. And you have to identify such people with glaucoma before they become symptomatic. So what we'll be covering today is tonometry, perimetry, and imaging devices for diagnostic purposes. Now, coming to angle closure disease, gonioscopy is still the gold standard. So, and significant angle closure disease are detected with the same technique as open angle glaucoma. So, apart from the suspects of angle closure, which you can, there's no real need for intervention as of now, what the literature says. But the other conditions like angle closure and angle closure diseases, they can be still detected by tonometry and perimetry and the imaging device. So we won't go into the angle closure part of it so much. So coming to tonometry, accurate tonometry is still not performed in the majority of patients who need it. And but tonometry alone has poor accuracy in detecting glaucoma, which we already know. And the corollary of that is also true. In the Baltimore Eye survey, the risk of having glaucoma in people with IOP more than 26 millimeters of mercury was 13 times higher than those with lower IOP. So as we all know, Goldman upnation tonometer is still the gold standard. Now we have numerous other tonometers which are newer, and especially the postgraduate should know about it. The dynamic contour tonometer, ocular response analyzer, rebound tonometer, home tonometers are coming up. And just for completion of the topic, the implantable tonometers, I'll be covering slightly on that also. So coming to a rebound tonometer, it's a miniature lightweight probe is launched in the perpendicular to the cornea. This is how the tonometer works. And the probe consists of a medical grade plastic tip with a metal shaft. The metal shaft is actually magnetized prior to measurement. And during a measurement, the probe is considered as moving magnet. It induces electrical signal in the surrounding coil, and that gets converted into IOP readings using an algorithm. So what you actually get is a reading output from the machine, but actually the machine anticipates that as a electrical signals. And the tonometer records the multiple parameters covering the motion of the probe, like deceleration, rebound time, and then converts that and gives you an IOP value. So this is how the tonometer looks like. And the advantage of this is the older versions, you could not do this in a supine patient, but now you have the tonometers which can be used in supine patients. And especially in pediatric eyes, it's quite advantageous. Now, having said that, there are certain possible limitations of this use, which you should know. The tonometers have been used in adult patients, but the company in its brochure mentions that patients with contact lens use, keratoconus, euphthalmos, microphthalmos, nystagmus, they have not been tried in such patients. And also such high corneal astigmatism. So these are the disadvantage of such using. So that's why Goldman upnation still remains the gold standard, especially if you have patients with corneal scarring, or if you have corneal thickness greater than 600 microns or less than 500 microns. Something like that, you may not be able to use these devices, or you can use them, but you have to use a clinical judgment to interpret the output. So when you have continuous monitoring, then next comes the continuous intraocular pressure monitoring. So you have a lot of sensors which are used for these devices. And I would suggest that you look into this article, which mentions the type of sensors, if you want to read ahead, type of sensors which are being used. Now, home tonometer is another thing which has come into vogue. Same companies which have the eye care tonometer, they have developed the home tonometer also. With that, the advantage of that is you can do self-monitoring, you can have better disease control, you can identify the peak IOP and the IOP fluctuations also, and the ability to measure IOP at different times of the day. And you also thereby have an improved quality of life. It's very easy to use. You don't need topical anesthesia, minimal risk of injury to the cornea. Measurement can be done in supine position, and very easily the data can be transferred. And you also can have remote monitoring is possible in these sort of situations. So this is an image showing a home tonometer being used by the patient. So iCare is one company which has a home tonometer device. So coming to the next topic, which is implantable tonometers. So because, as I showed you the previous slides, you have a lot of sensors which are available, and they monitor the biochemical and physiological information, which is transmitted from the home to these remote sites. And this transmission is held by Wi-Fi, internet, and this is also known as mobile health or wireless health. And of course, I think we know this because now everybody has an Apple phone and Apple Watch, and that also monitors your heart rate and other parameters. So you have something like the wireless health, and the sensors are the main components. You have various types of sensors like strain gauge, capacitive, piezoresistive, and because these are very robust and these platforms are very sensitive, they're able to perform these very nicely. So Sensimet Triggerfish was the first wireless device to be developed. It was actually a contact lens sensor. A soft contact lens with a circumferential sensor is attached, and it has two platinum titanium sensors, which are actually strain gauges designed to measure changes in the curvature of the cornea. And the microprocessor unit, it transmits the output signal via an antenna on the periocular surface, and the data is transmitted via cable to an external portable recorder. It's non-invasive, and it permits 24-hour ambulatory IOP monitoring, just like you have a 24-hour Holter or you have a 24-hour blood pressure monitoring device. This also allows the patient to go on his life on a daily basis and records the intraocular pressure over a period of 24 hours. So this is how the contact lens looks. And if you see the figure 1, that is the contact lens. The figure 2 is the antenna, which has been stuck to the patient's orbital area. And through a wire, which is 3, goes to a monitoring device, which is 4. And you can see that this is how the patient will appear if he has a device. And then the patient can go around his daily activities, and the intraocular pressure will continue to be recorded. Coming to the next is the implantable devices. These are designed for ciliary sulcus placement during cataract surgery. So they're known as iMate IO and iMate EO. So the IO stands for intraocular and the EO stands for extraocular. So extraocularly, you place it actually in the suprachoroidal placement for during a non-penetrating glaucoma surgery. So you don't enter the chamber, but you place it in the suprachoroidal region. So they are the ones which is implanted in the bag. It is a permanent implantable microsensor placed in front of the IOL, posterior to the iris. And the primary implantation can be done during cataract surgery in patients with open angle glaucoma. So this is how the sensor looks. And the implant is actually in front of the intraocular lens behind the iris.
iMate, your guardian for eye pressure. Increased intraocular pressure is causing visual field loss with glaucoma patients over time. In order to better guard and monitor the eye pressure, it is now possible to implant a tiny microsensor for measuring intraocular pressure. During standard cataract surgery, the clouded natural intraocular lens of the patient is removed. Thereafter, the foldable artificial lens is implanted into the patient's eye, a procedure performed in the last decade millions and millions of times. In addition to that, the flexible iMate microsensor is inserted through the same incision created for lens implantation. The iMate is placed in front of the artificial lens, but behind the iris, not visible from the outside. Post-surgery treatment is the same as after a cataract surgery procedure. The patient usually does not feel any implant irritation, and vision is established within a very short time. From now on, it is possible to take eye pressure readings anytime. For that,
So the advantage of this is you can get a permanent on-demand IOP readings. And the external device also charges the iMate. There's an external device which records the intraocular pressure, and that charges the intraocular device using electromagnetic coupling. And this is the iMate suprachoroidal space, which is implanted in the suprachoroidal space, and you can monitor the intactness of the device using a UBM. And these are all exploratory devices which you can do with doing a non-penetrating glaucoma surgery. Correlation with GAT was good, but not very exact, and there were certain complications. There were a lot of patients with hyphema, pain at surgical sites, and choroidal detachment, photopsia, intermittent headache. These were the mentioned adverse effects of these devices. Now, the implant data iMate, these devices are actually developed by a German company, and they are not actually FDA approved. So coming to the home monitoring system, so you have the iCare Home, and then which is a small probe, which is advantages are that you don't need anesthesia. Majority of the IOP measurements are comparable to GAT. Disadvantage, maybe it may have a little bit of overestimation or underestimation depending on how the patient is using the device. And you have a tendency to miss the nocturnal IOP readings. Whereas compared to the triggerfish, the recorded units are actually arbitrary because they record in millivolt equivalents, not in millimeters of mercury. But the advantage is that it captures the 24-hour IOP fluctuations, because this works on the principle of the corneal curvature being changed, and the contact lens senses that as the IOP fluctuates. And it also helps in capturing the nocturnal IOP fluctuation during sleep. iMate, compared to these two, it's a permanent monitoring, so you cannot remove it, and you can get simple on-demand IOP reading. So once you click on the device, which is external, and you want a reading, you record it, and then you can have a diurnal sort of a recording done over a period of time. And like I mentioned, it's not US FDA approved as of now. Coming to another devices which help you to titrate the intraocular pressure. So this is an iWatch device, and it's an implantable device. And the world's first adjustable glaucoma drainage device. And it has an internal rotating magnet disc, and it has a default.
The iWatch system is the world's first adjustable glaucoma drainage shunt. It is designed to drain aqueous humor efficiently, while allowing for an atraumatic adjustment of intraocular pressure according to each patient's needs. The system consists of the iWatch Flow Adjustment device, connected in series to the iPlate. The fluidic resistance of the iWatch device can be adjusted non-invasively by rotating its internal magnetic disc using an external control unit. The rotation of the magnetic disc around its eccentric axis allows for compression or decompression of the drainage tube, thus acting like a... The iWatch system is the iWatch device or decompression of the drainage tube, thus acting like an adjustable faucet. To implant the iWatch system, first implant the iPlate in a manner similar to other glaucoma drainage devices. Then, create an opening to the anterior chamber using a 25-gauge needle. Insert the nozzle of the iWatch into the anterior chamber and secure the device in place using 10-0 sutures. Connect the tube of the iPlate to the outlet of the iWatch. Verify its secure connection by gently pulling on the tube. Place and suture a scleral patch over the device. Finish by closing the conjunctiva. The iWatch's nozzle is rigid and is positioned within the anterior chamber parallel to the iris. This prevents any contact with the iris or the cornea, avoiding related complications. The iWatch system is adjusted atraumatically and precisely using the iWatch pen. On one end of the iWatch pen, there is a compass, which is used to measure the position of the iWatch device. On the other end of the iWatch pen, there is a magnet, which is used to perform the adjustment of the device. To perform the adjustment, place the compass above the center of the implant at a distance of 1 to 2 millimeters. Make sure to align the pointer of the compass with the implant's nozzle. The reading on the compass shows the current position of the implant. Positions range from 0, implant fully open, to 6, implant fully closed. To adjust the implant, place the magnet at the periphery of the implant at the position indicated by the compass and drag the magnet along the circumference of the implant to the desired position. Verify the new position of the implant with the compass. Verify the patient's ocular pressure and repeat adjustment if necessary. Opening the implant would tend to lower intraocular pressures, while closing the implant would lead to higher intraocular pressures. For more,
So this is how the image is there in the publication, and you can see the implant being connected to the place. So you can use a lot of devices like the ML glaucoma valve or the bar weld implant or the RD implant for allowing the pressure, the plate to, any type of plate can be used. You just don't have to use by any proprietary plate. You can use a valved or a non-valved device also. So coming to the measurement of the intraocular pressure, you have the Pascal dynamic contour tonometer, which is works on the principle of contour matching. That is, it matches the tip matches the contour of the cornea, and the advantage of that is that the factors affecting the intraocular pressure measurement, that is the corneal thickness, the rigidity, the curvature, the elastic properties, all these are removed. So it uses a miniature piezoresistive pressure sensor embedded within the tip contour and matched to the cornea. So it also doesn't measure the intraocular pressure directly. It measures the values which are the fluctuation of the pressure in the eye, which is transmitted into electrical signals, and then multiple readings over a period of 8 seconds, and then it gives you a output. And that pressure difference is translated into, using calculations, translated into a intraocular pressure reading. So this is how the mechanics of that work. And the curvature has a radius of 10.5 millimeter, and it takes about 100 IOP readings per second. And the whole cycle is completed in 8 seconds, and then you get an output. The advantage of this is that other factors of the cornea are taken away, and very useful for patients who have undergone refractive surgery or planning to undergo refractive surgery to get the intraocular pressure. And you can have a serial monitoring of the so-called true intraocular pressure. Coming to the ocular response analyzer, this is another unique device which helps you to measure the intraocular pressure, and also it gives you something called the corneal hysteresis, or the biomechanical property of the cornea. So it's a non-contact tonometer and provides IOP values which are independent of corneal properties. And it actually uses a long pulse of air, about 10 milliseconds. This causes the cornea to become appnated, and the air puff has to shut down. But there's a slight delay for the signal to shut down the air puff. So what happens, the cornea actually, the moment the signal is given, it doesn't stop pumping the air. It continues to pump the air. And the cornea from a convex surface becomes a planar surface, and then becomes a concave surface. Now, once it becomes a concave surface and the air pressure is shut down, it comes back to its original planar surface, and then retains its convex surface. So convexity. So because of that, you get two spikes, the applanation pressure 1 and the applanation pressure 2, as shown in the graph here. And this difference is calculated as the biomechanical property of the cornea, is known as the hysteresis. So this is something which we like to use to analyze the biomechanical property of the cornea, because that may also play an important role in glaucoma. Coming to fundus imaging. Now, portable fundus imaging systems are available. Now, fundus image has become so much evolved that you have wide angle, ultra wide field imaging system up to 200 degrees. To start off, 1975 was the first contact method of permanence of fundus cameras. Then you have now the RedCam 130 degree can be evaluated, but the situation, the unfortunate thing is that patient has to be in supine, but the images can also be captured in sitting position. This is very useful for ROP screening. That's where they use this more extensively. The other important cameras are the Optos, the Heidelberg Spectralis, and the ClearS 500 and 700. So these devices are non-contact. The advantage of them, especially if the ClearS, which is quite popular now, is you get a 130 degree in a single image, or up to 200 degrees in 2 images. The advantages of modern digital wide field and ultra wide field fundus systems are that you have enhanced resolution. You have very shorter image processing time, faster image acquisition, ease of image duplication manipulation, possibility of image transmission via electronic route, better acquisition in the eye with cataract than traditional fundus camera. Imaging a patient with small pupil can also be done. In non-compliant pediatric patients or patients who are aphakic and they have nystagmus, this still works better. And you can also see the central as well as the peripheral retina simultaneously. So these are some images of the ClearS 500 and the ClearS 700. These are the Spectralis, and you also have the Netra Forus wide field fundus camera. And you have the Netra RedCam and the RedCam by the group which has New Vision, which has developed the RedCam originally. Portable fundus cameras are coming into vogue. Now, if you go to any conference, you'll find that a lot of companies are coming out with their portable fundus camera, mainly for community ophthalmology purposes, as well as for screening of chronic diseases of the eye, like diabetic retinopathy. You have the Bosch portable, or the VOC. You have a lot of models with the VOC. And smartphone-based fundus cameras are also available. And you have these numerous, the Peak Vision, DI system, Ocular Cell Scope, MI2 RedCam, which has been developed by our colleagues in India, Remedio again by an engineer in India, and VOC. And these are some of the publications which are there regarding these. So you have a lot of the Pictor Plus from the VOC, and Horus, Smart Scope, Nidec. All these are numerous devices. These are just examples to give you types of handheld or smartphone-based fundus camera devices, which are easily available nowadays. The main advantage is that they have, just to give you an example of Bosch, so physical handheld, it has a supporting software. You can use it in non-mydriatic and mydriatic modes. Even a small pupil, you can use it. And they have a manual focusing up to -20 to +20. If it's autofocus mode, if a technician has to use it from -11 to +3 diopters. Coming to the perimeters, you have numerous perimeters. When I looked into this chart, I was shocked that we have 14 standard automated visual field devices available. We are very familiar with the Humphreys, which is what we have been using. Many people may not know, but if you were to jump from one device to the other, you lose a lot of back data. So that's why many people would not like to shift from one technology to the other. Coming to the visual field, Humphreys, the recent advances include you have the intermixing of the CETA standard, CETA fast and CETA faster. And there's a reduced step-up time with a single trial lens. So you don't have multiple lenses there. You have a liquid trial lens and you just enter the patient's refraction and it gives you the near ad, which has to be, and the lens itself will, it will change shape and allow the patient to perform the test instantaneously. And you also see the real eye position of the patient's eye as he's doing the test. So you don't need a higher Krakow method of checking his blind spot fixation or fixation target. You have a touch interface instead of buttons and all. You have touch interface on the screen. It has back compatibility with the previous versions, and you have faster testing time. Now, CETA faster is the newer testing strategy, and this begins with the patient. So what happens is traditionally it would start testing at the 4 cardinal points from 25 decibels. But now with the age match patient's threshold value, the test starts. So supposing the patient test has to start from 32, which is the age matched threshold value of the cardinal points of that particular patient, this test will start at 32. It won't start at 25. If it starts at 25, it will take a long time to go up to 32 because the patient is better than 25 decibels. So, and does away with the high Krakow method of fixation. And it is the half the test time of CETA standard and 70% of the CETA fast. And you can have a mixed GPA. So you can have one test you can do CETA standard, next is you can do CETA fast, and then you can do CETA faster. You will still get the GPA. The kinetic perimetry advantage also been enhanced because now you have instead of 90 degrees, you have close to 180 degree of usage. You have very good structure function correlation maps, and you also have the 24-2C program. So these are the advantages of the, and similarly, all other devices are upgrading the system. So if you are familiar with the device which you have been using, I think you should go back and read the operator's manual and also discuss with the respective companies to see what are the newer incorporation to software, hardware, which they are making. And coming to the portable visual field devices, you have the handheld devices and the virtual reality based devices. The handheld devices are, some examples. They usually work on the tablet principle. You have the Melbourne Rapid Fields, Visual Fields Easy, which is actually the iPad test, which is freely downloadable, and you can start doing the test immediately. Moorfield motion displacement test is also there. The disadvantage of these devices is that room lighting plays an important aspect when you do the test. And it's important for the patient to understand that the tablet has to be kept at a constant distance from the eye. So many elderly people are not able to hold the tablet for a prolonged period of time, and that can affect the testing parameter. Virtual reality based are numerous. From India, we have the LSR and the CFA, and there are numerous others which are available abroad. The advantages of portable perimeters are that they are less expensive than a standard perimeter. It's very convenient. You can have multiple headsets. So in the waiting room itself, if you have 5 headsets, 5 patients can do perimetry together at the same time. Whereas if you have only one standard automated perimeter, you have to put the patient on the machine one by one. Home perimetry can also be done, and these devices can be formatted to do visual acuity testing, contrast testing, and calibration testing also. And some of these devices which are developed abroad, they have a virtual assistant who talks to the patient throughout the process. So motivation, encouragement, all these are done just like you would have a semi-skilled worker asking the patient to do a good standard automated perimetry. The disadvantage is that you have higher variability because the background level of these devices are set. They cannot be changed, and they're not very wide because they have to use a standard screen. And testing to test variability is always present. So this is an example of the CFA VR perimeter, and the other one is the LSR AVA perimeter, which is a lot of these devices are now getting published compared to Humphreys Visual Field Analyzer. And as far as glaucoma patients are concerned, they have very good sensitivity and specificity, but specificity is slightly on the lower side. Coming to the optical coherence tomography, the advantage of this is that it's non-invasive, objective, accurate, rapid, reproducible, quantitative, and it's actually akin to tissue sampling. So you actually get an optical biopsy of the eye and the posterior segment, as you can see in the image below. And it helps to assess the optic nerve head, along with the retinal nerve fiber layer, macula, optic nerve vasculature. And if you use a swept source, you can also check the antechamber angle, and the outflow system also can be assessed. So the postgraduates, when you send a patient for imaging, you must know what the machine can do. So it's always better to know all the operating manuals which are there in your technical team side and go through them. So for example, if you want to send a patient for optic nerve head analysis using the OCT, you must make sure that his spherical error range of the spectacles is between -12 to +6 diopter. So less than that and more than that, the machine will not be able to resolve the situation. The axial length also has to be measured. So if you send somebody with an axial length of 20, you may get an output, but it will be a default output. It won't be the accurate output for that particular patient. So axial length has to be between 22 to 28 millimeters. So these are for the Carl Zeiss OCT, which is OCT 500 or OCT 5000 or OCT 6000. So similarly for Spectralis and other OCT devices, you will have these in the operating manual. So which you should look into and use accordingly. So highly myopic and hyperopic eyes have different RNFL profile, which you should already know. Disc size, the machine will not analyze if the disc size is less than 1.33 or more than 2.5. Now, we all know that the optic disc size in a normal population is varied up to 8-fold. So there's an 8-fold variation of the optic disc size. So machines are computers. So if you put garbage in, you will definitely get garbage out. Vertical CD ratios below 0.25. So if you have a optic disc which is 0.1, 0.2, if you send it for OCT analysis, you won't get an output. And the normative database does not include data from age of less than 18 years of age. Very few high myopes are included. So as much as possible, it's better if you are not an expert, better avoid doing OCT for high myopes because you may not be able to interpret the results. So the main advantage of OCT was that it helps in detecting glaucoma even before measurable visual field loss develops. And 17% of thickness of visual field loss, RNFL loss is required to detect visual field loss. So 17% is huge because the RNFL profile, what you get is something called the floor effect. So if you lose 15%, 20%, that itself is quite significant. And if you use OCT, you can detect 1 year before the visual field loss defect. You can detect progression of glaucoma 1 year before visual field loss defects. And as I mentioned, the floor effect and progression, if you hit the floor, then the progression has to be assessed using the visual field. Now you have macular ganglion cell and the ganglion cell inner plexiform layer component also to detect glaucoma prior to visual field defect. Mainly because unlike the optic nerve head, macula does not have a variation. Everybody's macula is the same. There is no change in anybody's macula unless they are suffering from, let's say, diabetic retinopathy or ARMD or something else. So macula doesn't change person to person. And the newer concepts which are coming up is that the ganglion cell complex and the GCI pair can also have a floor effect. So many people recommend that you start looking at the disc parameters. For example, the vertical CD ratio and the cup volume for analyzing deterioration in progressive glaucoma in patients with very advanced field defects. And this is just a printout of the OCT, which shows that you have numerous color codes, and each color code is of different significance. Some are for representative purposes, some are for statistical comparative purposes. And coming to the advances in confocal scanning ophthalmoscopy, you have an OCT, you have the concept of Bruch membrane opening, because what you see at the fundus is not exactly how the retinal nerve fiber layer goes out of the eye. So it goes out through the Bruch membrane opening, which is different from the Elschnig ring, which you see on the fundus examination. And the fovea to disc alignment also has to be done because many people have cyclotorsion. The cyclotorsion can range from -7 to +29 degrees. So every time the patient is imaged, the cyclotorsion has to be kept in mind. And this is because the registration of these devices is very good. So they'll register the image and compare it to the previous images. You also have softwares like the topographic change analysis, glaucoma probability score. These are all algorithm-based techniques, and they give you a change problem. So these are all advances in OCT, which for glaucoma purposes are very, very useful. Coming to the treatment modalities, now we have newer treatment modalities like the selective laser trabeculoplasty. And compared to the older versions of SLT, you now have the diode laser based SLT machines, which function both in the and they function, they're very hardy. And instead of using a ND-YAG, they use a 9 neodymium orthovanettate laser source. And that is a diode pumped laser. And the advantage of that is that the collateral damage is very less. And you can also have the SLT machine into a coagulation laser instead of a photodisruptive laser. So if you work on the ND-YAG, it is a photodisruptor. And if you work on the orthovanettate, neodymium orthovanettate, you make it work as a coagulator. So the same device can be used for a lot of other procedures. Like you can do a laser suture lysis, pan-retinal photocoagulation, argon laser iridotomy. And these are advantages of using a green laser along with a SLT. And the advantages of these devices are very intuitive. As you are doing the procedure, you can see what energy is being delivered, at what is the spot size, and all this can be seen just like a heads-up display in a car. You can use that, and the device also is very useful. You don't have to go back to the screen to change the parameters. You can just do it with the little finger. So these are so much for the investigations and the non-surgical procedures. Now we'll come to the surgical procedures, which the recent advances include the minimally invasive glaucoma surgery. And the advantages of minimally invasive glaucoma surgery that it causes minimal trauma to the conjunctiva. It also spares the sclera to a large extent, and they are all ab interno procedures, and they are bleb independent. So there is no late complication of, let's say, a bleb rupture or bleb infection or a requirement for a bleb revision. And the reduced surgical time, they can be combined with cataract surgery. Rapid visual recovery is there. Number of post-operative visits drastically reduce, and higher safety profile, and also cosmetically very acceptable, especially since you don't have a bleb. Mixed plus procedure, some procedure which I'll be discussing, like the Zen implant or the Infocus, which will involve the conjunctiva. So coming to the site of action, the trabecular meshwork is the main site of action for the mix. So you have the eye stent. You can stent it, or you can dilate it, or you can cut it or strip it, or you can wash it also. And you have suprachoroidal space devices which are placed in suprachoroidal space, and you can photocoag the ciliary body using endoscope. So that is also cycloplasty or cyclophotocoagulation. So these are the numerous devices which are available. In India, you have the eye stent devices, you have the trabectome, and you have the in the trabectome and the eye stent devices. The other devices like the hydras are yet to be, they are in the process of being introduced. So eye stent is a very small device which is heparin coated, and when you use this device, you have to use a surgical gonio lens. What it does is it gets inserted into the trabecular meshwork to increase the conventional outflow mechanism. And it's very useful for early to moderate stage of open angle glaucoma. So one caveat here is you may not be able to use it for angle closure disease. And one disadvantage is that if you have it blocked or if you have it dislodged, then you may not be able to recover it, because if you look at it, it's really like a small grain of sugar. It's very small. So it just fits into the trabecular meshwork. The hydras implant is another device which is again introduced into the trabecular meshwork. It is an intitol device. It works as an intracanalular scaffold. It is placed inside the Schlemm's canal during cataract surgery. Using the cataract surgery incisions, it increases the outflow because it increases the surface area of the Schlemm's canal. And it bypasses the trabecular meshwork by dilating the canal, thereby increasing the percolation. There are numerous other, these are some of the examples of the hand pieces of the gonio surgery devices. So you have, I discussed the eye stent. Now next we will go into the trabectome, which is US FDA approved since 2006. It's actually a high frequency electrocautery. It uses a a 19.5 gauge insulated footplate, which enters into the Schramm's canal through the trabecular meshwork. And you have an irrigation port and aspiration port. So what it addresses is the area of greatest resistance, which is the trabecular meshwork. So you have to have a surgical gonio lens like this. So the Swan-Jacob surgical gonio lens is the prototype surgical gonio lens. The advantage of the Swan-Jacob surgical gonio lens is it can be autoclaved and can be within a short cycle, you can use it in multiple patients. It doesn't cause scarring and preserve the conjunctiva. As you can see, the entry is through the corneal wound, and it is less risky than trabeculectomy. Once you have done the procedure, the trabecular meshwork is ablated and it is removed and aspirated. And then any heme which comes into the anterior chamber is washed. Now, this is an expensive device. So coming to the next excisional goniotomy, which is the Cahook dual blade. It is a, you have two blades which are side by side, and there's a ramp and a heel. So
this is Malik Cahook, professor of ophthalmology at the University of Colorado, and I'd like to share with you a case that I performed on the Orbis flying ocular as well as dependence on intraocular pressure lowering medication. We start off by placing the Swan-Jacob lens over the cornea coupled with viscoelastic. It is key at this point to zoom in so that the extent of your view is covered mostly by the gonio prism. You can see the excellent view that this provides to the trabecular meshwork. Once we've settled that the view is adequate for the procedure, we enter in with the KDB and tilt the tip 10 degrees up towards the trabecular meshwork to assist with entry through the TM and into Schlemm's canal. This is followed by settling the heel against the anterior wall of the canal and performing a 1 clock hour treatment at the area that we anticipate completing the second part of the maneuver. Here you see the second part where we enter into the canal about 3 clock hours to the left of the initial treatment, and we perform parallel incisions in the trabecular meshwork up until that initial treatment point. This allows us to produce a strip of trabecular meshwork that you can see here. I'd like to go over 3 techniques.
So it, as shown in the video, it cuts the trabecular meshwork very cleanly and minimizes fibrosis and closure over time. And you can do it standalone or with cataract surgery. Tanitos hook is another type of excisional goniotomy. The advantage of this is that if you look at the previous video, you'll see that you can operate only about 120 degrees, as shown in the image at the top. But if you use a pair of angled hooks, you can do about 120 on the nasal side, and you can approach supranasally and do about 120 again on the infratemporal side on either eye. So you actually have a larger area of excision up to 240 degrees of the trabecular meshwork. So this allows for a wider area of excising the trabecular meshwork. So you could have a much more lower intraocular pressure. GATT is the gonioscopy-assisted transluminal trabeculotomy, which was developed in 2014 by Drs. Grover and Feldman. And this is actually a 360-degree suture trabeculotomy, which was described by Dr. Edmund Smith, who was the former director of Moorfields Hospital in London. So the indications of this is primary open-angle glaucoma, juvenile open-angle glaucoma, pseudoexfoliation, pigmentary glaucoma, and congenital glaucoma if the cornea is very clear. And what you do is you introduce a suture into the eye, and using a surgical gonio lens, you make a small nick in the trabecular meshwork using a MVR blade or a 26-gauge needle, and you use the Grishaber forceps or a grasping forceps to introduce the suture into the Schlemm's canal. This is a 5-0 proline suture, and once the suture goes into the Schlemm's canal, it will come out the opposite side, and you hold the leading edge and tug at the trailing edge, so as to open the trabecular meshwork to the aqueous humor into the anterior chamber. So the disadvantages, of course, you get a reflex of heme, but the advantage is that you preserve the conjunctiva, you open the trabecular meshwork, and you have a lower intraocular pressure. So these are the type of gonio lenses which can be used. These are all surgical gonio lenses. Some of them can be brought from the companies which manufacture them. Some of the companies which market the stenting devices we'll give this to you as a bundled device. So the Prism S Prism gonio lens is from the Glaucoma Incorporation, the Hill gonio lens for the Ocular Incorporation. Coming to situations where you may not be able to do stenting procedure, especially if you have reflux of heme, for example, patients with anticoagulants, using a lot of antiplatelets and fluctuating blood pressure, you can use non-penetrating glaucoma surgery. The advantage of that is it reduces the intraocular pressure by external filtration of aqueous humor, something like a trabeculectomy, but you don't enter the antechamber. So the complications of conventional trabeculectomy are not there, like shadowing of the chamber, choroidal detachment, overfiltration. And you do this by generating a trabecular Descemet's window. So through that window, the aqueous humor percolates and through the inner wall of the Schramm's canal, and you form an intrascleral lake, something like a decompression chamber. Now we can go on to do another procedure, which is the canaloplasty, where you introduce a suture into the Schramm's canal, which is the 50 proline, and then you tie a 90 proline, and then leave the 90 proline into the Schramm's canal and tie it tightly, so that you bring the inner wall of the Schramm's canal closer to the anterior chamber. So increase the surface area of the Schramm's canal, thereby enhancing the flow. So this is a canaloplasty procedure. So once you have is the video playing?
It stopped now.
Stop now. Okay, I think it's not playing. Sorry about that. I don't think I'll be able to show you that. It doesn't seem to play now. So nevertheless, the advantage of canaloplasty is you don't have the hypotony with maculopathy, which usually accompanies conventional trabeculectomy. You also don't have choroidal effusion. It's a blebless procedure. So bleb-related complications later on in life are extremely remote. Mitomycin C is not used in this procedure. So infections, blebitis, bleb-related endophthalmitis is also very reduced. Of course, as we do the procedure, the data will be required. So coming to the newer glaucoma drainage implants, we already know that we have the Ahmed glaucoma valve, which is the valve device, and you also have the bare-weld glaucoma implant. Now you have the RD implant, which are non-valve device, but these companies are now coming up with their own the counterparts of those devices. So for example, if you have a valve device, they also want to have a non-valve device. So Ahmed is coming out with a clear path. Paul glaucoma implant is another device which is going to be maybe launched in the near future. Many of our clinician scientists are experimenting and implanting these devices and seeing the results. So they may go in for approval, and we may have this device soon with us. Zen implant and PRESERFLOW implants are already available in the Western markets, and I'm given to understand that they will be launched soon. So these are small devices which help to percolate the aqueous humor from the antechamber into the subconital space. So just to show you a video of a Ahmed clear path. So this is a non-valve device. It's a very low-lying device made of flexible material. It easily fits into tight orbits, and in childhood glaucoma, where you have a large eyeball in a small orbit, and you have eyelets which are very anteriorly placed. So suturing is very easy. You don't have to ask your staff to tug at the traction suture so much so that suturing becomes so difficult. And you also have a pre-placed ripcord suture. So it doesn't allow immediate hypotony once the ligature opens up. You still have a suture inside the tube to prevent hypotony. So these are the advantages of using the non-valve device with a ripcord suture. And coming to the Paul glaucoma implant, you can see that it's a very small device, very nicely finished. And compared to the bare-weld, it is smaller, but compared to the Ahmed, it is slightly larger. And the main advantage of the Paul glaucoma implant is the tip. If you look at the tube size, it's 0.1, whereas the Ahmed and the bare-weld have 0.3. Even the RD has 0.3. So the chances of overfiltration are very, very less. So the tube is very micro-sized. It's almost the size of a smaller Zen implant, and the optimized plate design is very helpful. And the medical grade silicone attaches and gives you a very nice adherence to the sclera. And it's a very flexible device, and reduces both microabrasion and excessive wound scarring. So it's something which we are looking forward to once it becomes more commonly available. Zen gel shunt is gelatin derived from porcine dermis and formed into the tube and cross-linked with glutathione. So when it becomes hydrated, there's minimal swelling. It's very soft and becomes flexible. You have small sizes, and if you look at the image, it goes from the anterior chamber into the subconjunctival space directly. So there is no need for any scleral dissection or anything. So these are known as the mix plus procedures. So they require a little bit of conjunctival dissection, but not too much. At the same time, mitomycin can be used for enhancing the filtration, and they function as a mixed device. Sorry, I think this video is also not playing. Sorry about that. So pressure flow is the next implant. This is again made of inert material, which is utilized for coronary stents. So theoretically, it will reduce the episcleral scarring and fibrosis. And the distal end of the device should filter the aqueous humor into the subconjunctival space 6 mm posterior to the limbus. Same as the gel shunt, the Zen gel shunt. And it's placed via a tunnel in the subconjunctival space into the anterior chamber. Mitomycin C has to be used to prevent fibrosis. So unlike at conventional trabeculectomy, you don't have to lift a flap, but you can just place these devices into the anterior chamber and leave it in the surface and cover it with the conjunctiva. So with this, I would like to stop here. I hope it was useful. Newer devices, newer diagnostic devices are very important as far as PGs are concerned. And I think there's extensive reading to be done in this respect. Thank you very much. Any questions, I'll be happy to answer.
Thank you. Thank you. Tinku, ma'am.
Thank you. Yeah, thank you, Dr. Raman. That was an amazing talk. It sure is a very exciting time for glaucoma specialists, I must say, with such a surge of new innovations, new technologies, new diagnostic methodologies. And thank you so much for introducing us to this amazing cutting-edge breakthrough that you introduced us to in glaucoma diagnostics and treatment. You also rightly pointed out the fallacies in the optic nerve head and RNFL measurements that we all should keep in mind for patients in whom there are no normative databases. So that was a very important point that you pointed out. We have a few questions. So I'd just like to ask you, is the home tonometer available in India? And if so, how expensive is it?
Yeah, the home tonometer is available. I think it's ranges. You have the two versions of it. It's from the eye care company, no financial interest. There are two versions. One of them can be used in supine position. So that's the advanced version. And that's how it's easy to differentiate the other one. So I think it's about, it starts off by minimum of 2 lakh and then goes up to 4.5 lakhs.
Okay. So the other question is to the panelists, Dr. Kalyani, if you could take that question. So how accurate is the rebound tonometer as compared to the Goldman's applanation tonometer? As we know, it has different readings in the supine and sitting position. So what is the accuracy and what is a good tonometer to be used in children? That also we would like to know.
Yes, ma'am. See, the rebound tonometer, it is very easy to use and anesthetic drops are not needed. As in supine position and children, it is very useful. But when you compare to the accuracy, definitely the Goldman tonometer, that is very near to the Perkins. So we prefer Perkins. But when it comes to the supine position and scarred corneas and all such cases, we can use the rebound tonometer.
Thank you. A question for Dr. Surajit. So, would the OCTA, that is the OCT and geography, in any way give us information about glaucoma progression in the future? Are there any programs in the OCTA which we could look at? If not now, maybe in the future.
Maybe future it may be possible, but right now about the diagnosis part also about for glaucoma, the OCTA doesn't give us much information, because whatever damage has been done, we don't know whether it is because of the vessel loss, what is happening there. It is because of that, or because it is the damage is happening because of that these vessels are lost there. So this much there is some confusion about that also. So for our glaucoma diagnosis and prognosis both part, right now, definitely we are not depending on that. And also it is a very expensive machine also. For only for glaucoma purpose, we are not using it. But maybe in future, if different software or something coming, it may be able to evaluate it. But right now, we are not using it.
Thank you.
Madam, can I add a point? I agree
Yes,
with
please.
Dr. Surijit. We don't know whether the GCC loss is because of vessel loss or the vessel loss is because of GCC loss. We don't know that. The other aspect which the postgraduate should remember is for the OCTA, there is I don't think there's any normative database. So as of now, I don't think that has been developed. That could also be one more reason why we are not looking into it so much. Would you agree, Dr. Surijit, Dr. Shahinur?
Yes, sir.
I got one question. Is rebound better than NCT for routine checkup, or NCT still is good for screening purposes?
So both of them are actually for screening purposes. And when we do these devices, when you use these devices, we should know the range at which they measure the intraocular pressure. For example, non-contact tonometer will measure, it has two settings. The puff of air which has to be ejected has to come with one force for one range of IOP and higher force with the higher range of IOP. So all these NCT will have 0 to 30, one switch, 30 to 60, another switch. If your technician doesn't know that he has to flip the switch to take the reading, so a pressure of, let's say 46 or something will be shown erroneously. So routine screening, you have to see if it's already a pre-existing glaucoma patient, silicone oil is there in the eye, he is sent home and he's coming back for a repeat checkup and his pressure is more than 30. Then the switch has to be flipped to 30 to 60 and then taken the reading. That's why we don't always get a match between the Goldman and the NCT, because we don't do it in a proper way. And similarly, there's a caveat for the eye care that these eyes of the pathological eyes have not been studied using the eye care. So they've just done normative adult normal patients who are not even actually having glaucoma.
I would just like to add here once that NCT we are using routinely only for screening patients. But for proper glaucoma patients, it is the applanation tonometer which is to be used. That is the recommended tonometer.
Agreed.
Can I ask one question on a OCTA? We are seeing a lot of parameters to be used, like perfusion index and all those things. So are you people now, at least in the institute, thinking about it? And what is the normal perfusion index at particular close to the peripapillary region? Do we have some normative data for Indian eyes from the institute and all?
No, I don't think so. We don't have, sir.
Sir, OCTA for glaucoma, I think it is still in a developmental stage, wherein we are still looking at the superficial vascular complex and comparing with the deep vascular complex, which is more reliable. We are still at that stage. Going into perfusion index, I think it's still not there.
What about the micropulse laser, transvascular cyclophotocoagulation? Is micropulse laser, what is the present status of the micropulse laser?
So micropulse, we have the device. The problem is I didn't include it into this talk because although it's a newer device, it still has its own learning curve. The company support is good, but it's become very expensive. And the probe cost is changed. The probe design has changed. The cost has also increased. So with all these factors, and since it is not contributing to our patient care as much as a diode is doing, we are not using it as much. Although we like to use it, it's safer. But there's a lot of inputs from the promoter side which are not very comfortable for us to use it on a daily basis.
For your information, actually, the insurance company pays whatever you send for this procedure. Actually, I sent 52,000. They give it to us without any problem. So because they are not listed on their price list, so there is no problem so far as the cost is concerned in TPA patients. So I've been charging 52,000, and the insurance company has never questioned us. So you can use it, and of course the results are a little questionable in certain cases. And I do not know. I mean, I would like to ask the panel whether the patients with diabetic retinopathy or any contraindication for that, there's it causes more CME and so forth.
For the micropulse, sir?
Yeah. Well, is there more chances of developing a sustained macular edema versus cyclodisruptive procedure to some extent?
Dr. Surijit, you want to take that?
Can I answer, sir, for this?
Yeah.
Yeah, in fact, some micropulse, they say the inflammation is very less because of the cold, these things, the reaction and the inflammation is less. So that way it is beneficial when compared to TSCPC.
So for
On and off, on and off laser release is there. So they say it is better, inflammation is less.
So all of you have your personal experience of using it?
No, sir, no. Only
yes, sir,
like I heard from the
So we have
conference
it.
and-
We have used this machine or this micropulse laser, but the thing is that sometimes it becomes a little bit unpredictable. For as good as it was told that for the diode CPC also that if sometimes I might go in the hypotony also, sometimes it may not work also. It happens, but micropulse, it was said that it is the power will be less, and definitely the chances of over-treating will be less, and collateral damages because of the laser, that will be also less. So inflammation is definitely less. The eyes are quieter after the procedure, definitely, but the effect there is a little bit doubtful still about it. And what sir just mentioned about it, there is some change in the probe also. That was informed by the company to us also, that they are changing the probe. So maybe after that, the efficacy might improve, but right now it is a little bit unpredictable. We are not advising that much in those patients.
So for the such eyes, we have other modalities also. For example, if it's an open angle with neovascular glaucoma or something, we can get away by doing a trab. Now we have better tubes also. I think we are comfortable doing tubes on those eyes rather than planning for a diode or a micropulse. We prefer to do a diode or a micropulse after the tube, because the superadded effect of that drainage device following a diode, it's quite huge. So you get a severe hypotony after the procedure. So we try to do these procedures before doing a micropulse or a diode.
There is a question
Actually-
from one of the PGs. I'm sorry, sir.
Yeah,
Please go ahead.
Good. I think just only thing initially when they recommended 180 degree, I used 180. It was not effective, so I started using 360 degree virtually, leaving the vascular area. And now whenever they neovascular glaucoma, I actually use 2 rounds of 360 degree. So whatever they recommend, probably you need double the dose for it to be effective. That has been my experience, a limited experience. I've not done many, but 30, 40, whatever I've done, that has been my experience.
Can I ask one question? This is a question from one of the postgraduates. He's asking which procedure you would like to do in this. You have described various cannuloplasties and all those procedures. In which condition should you do which procedure? That's what his question is.
Yeah, that's an important thing. So, for example, if you we have our own gamut of list of procedures where we plan, and the indications we have. Actually, each institute or each practitioner or group will have its own plan for managing such situations. So not everybody can do all the procedures. That's also a given. So for open angle glaucomas, we prefer to do, if the patient is not having any systemic comorbidities, we prefer to do a GAT, because we preserve the conjunctiva for future surgery. So if it's an angle closure glaucoma, which is very early, we prefer to do a trab. If it's advanced glaucoma, if it doesn't have cataract, we just prefer to do a trab. If it has cataract, we do prefer to do a combined procedure. And you could titrate it according to the, so the idea is that you individualize what the patients require and then offer the surgery to him. For example, patient with clopidogrel and other antiplatelets, he'll be better off by not entering the chamber in any way, so that you can address the condition by doing a non-penetrating deep sclerectomy or a canaloplasty. A patient coming with neovascular glaucoma will definitely require to have a bypass the trabecular meshwork. So he'll require a tube shunt, which will bypass and take the filtering site away from the site of inflammation, which is actually the anterior segment where the blood will not work. So we look at the patient's systemic condition and the eye condition and then plan for the surgery.
So if there is no contraindication, can we safely say that the trabeculectomy still is the gold standard and no other procedure has got better outcome than trabeculectomy? I mean, if there is no contraindication for trabeculectomy, that means there is no scarring or there is no iris adhesion to the cornea, no new aspiration. And if there is no other issue, can we say that all other procedures have less effectivity or less predictability as compared to the trabeculectomy?
Yes, yeah. I would agree with that. They are less effective, but their safety is what we are looking at, because we always have to look at the second chance the patient can be given. So once you have,
is it not possible you can give a second chance if the trabeculectomy fails?
You could, but if you can give a 3 or 4 chances, why would you want to give only 2 or 3 chances?
It's one and same. Whether you do trabeculectomy first and then do the other procedure, or do the other procedure first, and if that fails, do trabeculectomy. There is no doubt that more fields are very exciting and more cosmetically acceptable, more technically demanding, and something to look forward and something to really raise the bar for the glaucoma surgeons. And it comes into the domain of the pure glaucoma surgeons, not with the general ophthalmologists who can do trabeculectomy very easily. But it's a very, very exciting field. There's no doubt about it. Very, very exciting field. And something happening for many years, nothing was happening on the glaucoma field. So now suddenly there are a lot of things happening on a glaucoma field.
One more question.
At one point, sometimes it can happen the reverse way also. We preserve the conjunctiva for the last for a trabeculectomy, and maybe we try the angles first. But there are many patients who have undergone trabeculectomy in the past, and now again they have a failed bleb, and the IOP is very high with maximum medication. And I've seen particularly in children, they have really worked with angle surgery. So sometimes it can happen the other way also. If there's no more conjunctiva for any more filtering procedure, then angle surgery can also save the situation.
Periodic cataract is entirely different ballgame.
I would like to add one point here. The most of the MIGS surgeries, they are mostly done to improve the quality of life of the patient, to reduce the burden of the medications and all the side effects of the medication. And mostly if it is used in mild to moderate glaucomas mostly. For advanced glaucoma, is still rely on the, I think the trabeculectomy is the thing, gold standard thing. And there is less chance to take, then definitely we should go for that also.
So what, I mean, suppose if the patient's 1 medication, 2 medication, 3 medication, 4 medication, what is the limit of the medication you can give? At what level you will decide, okay, even if suppose patient needs 4 medication or 5 medication, that, okay, this is my cutoff. If patient needs more than 2 medicines, I'm going to go for invasive procedure, then keep on adding 1 more medicine and keep on following the patient.
So adherence, the compliance and adherence is always an issue in our lifelong glaucoma therapy for the patients. So most of the time it is said that if 3 drops a day, if the patient can continue, that maybe in 2 bottles 3 times a day, if the patient is putting the drop, that may be possible to use that for longer duration. Anything more than that, it will be very difficult for the patient to continue. So in that case, most probably if the surgery can be think about, but it is not a rigid rule, but definitely it can be considered.
So I think by the time we write the 3rd medication, the next stage, we keep a very low threshold for surgery. So by the time the patient is on the 3rd molecule, the level for surgery threshold is kept very low.
Because in any case, I mean, the first medication gives more effect than the second medication gives less, 3rd, 4th. I mean, if you keep on adding medicines, the IOP will not lower to that extent. I mean, if the three
Correct.
medicines are brought it down
Absolutely.
to 25, the fourth medicine can bring it down to 23. It won't bring down to 25% or something of that type. So I think after three medicines, if it is not controlled, probably the patient is definitely in for surgery.
Yes, sir.
One more question is there. The non-walled glaucoma devices, sir, he says that previously there were non-walled, they moved to walled for making it more safe. Now, why again you're talking about the non-walled development?
Yeah, so for the valve device, with the valve, they go in for something called the hypertensive phase. They go in for a hypertensive phase. That hypertensive phase continues to get prolonged over a period of time. There are ways of coming over that hypertensive phase, which is actually, some publications have mentioned that you can give post-operative injection mitomycin C. You can give indomethacin or brufen to control the inflammation. You can start anti-glaucoma medication from very early stage. The moment the intraocular pressure crosses more than 10, you start aqueous suppressants to control the hypertensive phase of the valve device. Valve device, they were designed to give safety more than efficacy. But now and they were expensive. In India, they were extremely expensive. Even now, the valve device is minimum charges around 24,000 rupees, plus you add the cost of the surgery. Now with the RD coming in, you have a cheaper device, less expensive device, which is $15. Now, the only issue is you have to make it into a safety profile. So with the ripcord suture, the whole market has changed. Now the companies which were selling the valve device also got their own non-valve device, because they see that the market for the non-valve device is huge. With the ripcord suture, you let the suture inside, you remove it as the intraocular pressure builds up over a period of, let's say, 3 months or 4 months or 6 months. You have that window period of removing the suture anytime during the course of the patient's life.
But even the Arvind device works very well, I think. Is there any further modification? I've used some of the Arvind drainage devices. They are excellent. I have no problem with them. Is there any
Yes, sir,
further
they are.
modification? Yeah.
No, that is from a simple mold, sir. That's from a static mold. So more modifications on that will not be possible. But I think they'll give some value-added services, like they may give nowadays the 23 gauge needle doesn't come with a Dispovan syringe. So we have to hunt around for it. It's not easily accessible. The ripcord suture may be of a different material. Maybe I prefer a Prolene, but the company gives separately from the nylon. So you may have some value-added service coming into it, but the model cannot be changed.
Maybe you can ask them to provide some preserved sclera to put it on top of that.
Yeah, that could also be something, but
something of that type. Because
that is true. That is
routine surgeons may not have that type
correct
of capacity.
That is another reason for delaying the surgery, because they are not able to procure the sclera, so they delay the surgery also.
Is there any problem if we make a trabeculectomy like flap and then put it over there?
No, there is no problem. I usually do a scleral tunnel technique. So I make a scleral tunnel and then put it using a track. So my tube is covered for about 8 millimeters in the sclera.
And if you make a trabeculectomy like flap and then suture it, is there any problem with that?
No problem, but it won't be a snug fit. So you have peritubular leak, which may complicate the issue. So you don't know what is leaking, whether the ligature has given way or the track is leaking, or what exactly is happening, you will not know.
So what I do is I put on a parallel suture to the tube on both sides. When I make a trabeculectomy like flap, I put on a suture just adjacent to the tube on both the sides.
Correct, sir.
And so the gap is on the sides, but the tube is very snugly fit over there. It won't move at all. So
yes, sir.
I slightly left on the side open, but the tube is fully and covered, very tightly covered over there.
There is one more question I can ask any panelist to answer. The student says that what is the indication of using this continuous monitoring devices? In which condition we should do it, and when should we do a static tonometry? What are the indication? Implantable. That's what he means, I believe. I think we can ask Shainur or Surajit to answer.
Yeah. If you mean the implantable, then I think in very advanced glaucoma patients where we want to monitor the IOP fluctuation in a continuous manner, that would be an indication. But as far as the contact lens is concerned, I think it will have more application for the DV-IOP or the diurnal variation that we have. So in that case, we can have a 24-hour IOP reading just to see the IOP fluctuation in that case.
So maybe in some cases of unexplained loss of vision, when the patient visits to your office and the IOP is normal and MRI is normal, everything is normal, you do not know what is happening to the patient. Totally unexplained loss of vision when you want to monitor what is happening to the patient's eye.
Sure. So there's one last question. I think we already reached our limit. One last question. What should be the testing program that we should use in a patient who's a glaucoma suspect? Like there are studies which say that even the central points should be tested. The 10-2 should also be tested. And Dr. Raman spoke about the 24-2C program, which also includes macular area points. So which are the protocols? Do you use 24-2, 30-2, 10-2, or all of them, or few of them? So I just like to ask the panelists. Dr. Raman?
For the glaucoma suspect, the first time we do a 24-2, we don't have the C strategy. 24-2C we don't have, we do a 24-2, and if it's a if we find that it's a we do a 10-2 as well for those patients in the same sitting, and that's how we analyze them initially. But after that, if they have the risk factors for glaucoma are less, then we shift them onto the fast strategy, and then they continue to get followed up.
So the other panelists, do you do anything different, or do you follow the same? Dr. Shahinur?
Yes. If it is a glaucoma suspect, then initially in our institute, we are doing routinely the 30-2. It has been going on. So we have not shifted to 24-2. So 30-2, and if everything is normal in the 30-2 and clinically also we find that the disc is looking healthy, then we don't do a 10-2. But if there is even a paracentral scotoma in the 30-2, even one scotoma, then in that case, a 10-2 is done. But routinely for glaucoma suspects, we'll do the 30-2 only.
So the other panelists, should we include 10-2 in our treatment, in the testing strategy or not?
Yeah, actually, if we have access to
That's what I would like.
to see the central points, if we have it, since the HVF3 has those strategy, and also Octopus machine also have those possibility to assess the central point. If we have it, we should include it, definitely. If we don't have it, then definitely only 24-2 gives information. And if you have strong clinical suspicion, there might be a central point might be affected, or little bit of sensitivity reduction is seen in any paracentral points, then we must go for the 10-2 separately.
Thank you. You're muted.
There is a question in the chat box. Mansi, Dr. Mansi Karia, what about vent incision in RD? I think we can have from one of the panelists.
Yeah, we give venting incisions into the tube ahead of the ligature. So you could do that, and that helps you to reduce the intraocular pressure very quickly on day one. The venting slits sort of get fibrosed over a period of 15 days, 3 weeks, by the time the intraocular pressure starts increasing again. So for a temporary reduction, you could do it. You could use a 8-0 vicryl suture needle, which gives you a larger incision. And either you can do it through, or you can just cut on the slice. If you have a ripcord suture, you must give venting slits because everything is blocked. The ligature will block it. The flow will be reduced because the ripcord suture is in the tube. So venting slits helps a lot when you have a baseline pressure, preoperative pressure quite high.
Thank you.
Okay. So any more questions, or should we call it a day?
I think so. I think
So. Yeah, so I thank all the speakers, the panelists, Dr. Ganesh for giving us this excellent talk. I also thank Dr. Harbans Lal for his continued presence in this webinar. And thanks to all the attendees, the postgraduates who attended this, and hope to see you in the next webinar very soon. Dr. Prashant, any concluding words?
Yeah, it's once more, thank you, Dr. Ganesh, Dr. Shainu, Dr. Surajit, and Venkat, madam. And of course, our own president, who has been a constant source of support. I look at his energy. He has been right from the beginning till end. We are really thankful to you, President Sir, for getting us into this activity, which we have started enjoying as well as a ARC team. Thank you once more. It's time for us to say goodbye. We'll be catching up again on the following Thursday, exactly at 8 p.m. That time we will be having something on GDX, perimetry reading, and what is that? Perimetry and OCT in glaucoma. So looking forward to that. We will be catching up again. Thank you once more, all the esteemed speakers.
Thank you,
Bye-bye.
everybody.
Thank you, sir.
It was wonderful
you.
experience listening to it. It was really great information and a knowledge for me. Thank you, everybody.
Thank you, sir. Thank you.
Good
Thank
night.
you.